Right. Hello, everyone, and welcome to yet another edition of the Wind Focus Ultrasound Journal podcast. My name is Adrian Wong. I'm a consultant in critical care and anesthesia at King's College Hospital, and I'm joined once again with my partner in crime, Professor Francesco Corradi, editor of the Ultrasound Journal. And we've got a rather interesting one for our listeners today. I am joined by Stefan. Stefan, why don't you introduce yourself to the audience and listeners?
Well, thank you for the invitation. My name is Stefan Katzenschlager. I have a German name, so let's keep it to Stefan. I'm a specialist in anesthesiology in Heidelberg, Germany, and we have a subspecialty in pre-hospital emergency medicine. We don't have an own emergency medicine specialty, but a subspecialty. Yeah, that's about myself.
Okay, and he's already given the game away here because as he said, he's a pre-hospital specialist. So, the title of his paper and manuscript, which we are going to discuss today, take a big breath, Adrian. It is Assess, Improve, Detect, Guide, a narrative review and proposal for a standardized protocol for pre-hospital transesophageal echocardiography during out-of-hospital cardiac arrest. Now, that's quite a mouthful. Stefan, why don't you share with us the key findings from your paper and then we'll dissect it down.
So what we have done, and the idea comes from using, let's see, it's call it TEE for the
TE, yep, we'll use TE from here on in.
from here on. Yeah. So the idea comes from using TEE for eCPR to make this in the pre-hospital field even safer. And with TE available in our pre-hospital eCPR service, we then went on and said, okay, how can we standardize this this ultrasound method and use it to the maximum value?
Okay.
And
We're going to
that's
go dissect down in all the details there because you've got a really nice infographic, couple of nice illustrations which we'll share to our listeners. But before then, Francesco, your thoughts as an editor-in-chief of the Ultrasound Journal. Why did you choose to publish this paper?
Thank you for the unplanned question, really, because I want to be very, very, very honest with you. I think it's important manuscript because from the scientific and didactical point of view, and I think the authors find a balance between that didactic and scientific approach. Very useful in order to improve or change clinical practice. But to be very honest, when I first saw the title, my first thought was, oh my gosh, another manuscript on TEE on out-of-hospital cardiac arrest. Guys, why? It's something is already published, so that's enough. No, there is internet, PubMed. I can find it online, but I'm interested. I'm interested because it's my field of not expertise, my field of passion. I'm really interested, and I'm interested more because I want to see. I said myself, I want to see what they said. If they said something different and something new. And I want to compliment with the authors because for some reason that if you want, I will explain you. Your works were well done. Interested me for sure because it's new novel, very interesting. It was not so easy concerning the topics because I have had a lot of manuscripts that are just released also in these days and weeks on the same topic, out of hospital cardiac arrest, TE, how to do, or some protocols that simply state wrong things, simply wrong. Okay, and the reason are, or the manuscript were written by people that never saw cardiac arrest, or maybe by people that managed cardiac arrest without ultrasound. I'm really sorry to seem to be blunt, but this is what it is. Because the authors propose a manuscript that is really pathophysiological based, and by reading the manuscript, I really convinced they do what they about.
I know what you mean, Francesco. So, Stefan, we're going to get your thoughts in a second, but I'm going to be, again, very honest in terms of my experience. I am definitely not a TEE expert. In the UK, I think it's fair to say that the UK, even in critical care, TEE lags behind compared to some bits of Western Europe. And I know some of my intensive care colleagues who are practicing in Belgium and Paris are still laughing at me because I still preach down thoracic whilst they're doing transesophageal. So in my hospital setting and in the region where I work, London, we're only just starting ECPR, only just. So we're far behind our Parisian colleagues, and we're very behind in terms of you in the German colleagues. So share with us your experience with TEE in the out of hospital, in the pre-hospital settings. Tell us a bit about your training, the logistics. I know you've mentioned it some of it, but just share as a taster, if you will, Stefan.
Yes. So our experience stems from about 2 years or something like this now, maybe just over 2 years. And first, we used it as a safety measure for ECPR cannulations, demonstrating both guide wires in the right vessel, locating the venous cannula, and making this operation more safe. And then we started to use our knowledge from cardiac anesthesiologists to get a feel for, is the patient in VF? How does this look? Because we see it in the OR, right? When the patient goes into VF, we can then look at it on a TEE, and we can translate that knowledge into the pre-hospital setting. And we
So
can also,
were you doing TEE already before you in the anesthetic theatre setting before you went into the the pre-hospital setting? You're already competent and proficient doing it.
so we are not all, we don't have not everybody has a diploma. So the European diploma of critical echocardiography, we don't, so some of us have it, but not the whole team. But nevertheless, we either do it in the intensive care unit or in the theater on a weekly basis. I wouldn't say daily, but weekly basis. So we have a good experience handling the probe, getting the views right, having a good feeling for it.
Okay. So as an experienced person, and I'm going to rope Francesco into it, one of the key sections I really liked about the paper is that you have a section entitled Implementation, Logistical Challenges, and Proposed Training Level. And in your proposed training level, you said that the recommended guidelines suggest a minimum of 10 esophageal TEE examinations on patients and simulators. So there's a bit of a balance between the two, yeah, as a minimum for doing this. Your thoughts then in real world of that's what the literature says. What do you think as a trainer? And then Francesco, you can come in terms of the training side of things as well. How many do you think before you unleash these people onto the pre-hospital world?
I would say definitely more than 10. So you have to take into account the whole logistics in the pre-hospital setting.
Mm-hmm.
You basically by yourself, you don't have an anesthetic nurse that helps you. You maybe need to tell the paramedics what to do now because they haven't worked with a TE probe as well. So I would say around doing 50 and having or keeping in mind when you do this in the OR, what are my steps when I'm alone? what I'm gonna do, how do I need to tell it to the nurses or to the paramedics when they don't know how to assist me in performing TEE, especially in probe insertion and preparation.
Okay. Francesco, thoughts then on training in transesophageal echocardiography? Because it's a focus one, and we'll come to the focus bit later. Your thoughts on the training side of things, Francesco? 10?
I think that there are some specific issues, and the first issue to be fixed is represented by the introduction of the probe, because this is very, very important in order not to harm the esophagus and in order to try not to displace the orotracheal tube. And I think this is a very important probe. So just before the assessment of the heart, this is a point where you will face with a patient that will definitely will be not prepared, such as in the operating room. The second point, I got it that we are not talking about formal TE assessment, but we are looking only some point of care TE examination. But really, once again, to be honest, I think that 10 exams are not enough. But it's my
like so 10
personal
sounds like
experience.
10 sounds like a really low number, and I suspect we'll be putting some show notes on later on in terms of digesting this 10, because if you look at less invasive ultrasound, say lung ultrasound, which is a relatively non-invasive, fairly straightforward. I know some people are going to hammer me for that one, but we're talking about 30 scans before people get comfortable. And when we think about the complexities of echocardiography, cardiac ultrasound, and a number you'd think higher. So the number 10 seems very, very low, and I'm sure some colleagues will comment on that. But as Francesco said, and I'm going to ask you now, Stefan, this is about a very, very focused examination. Okay, so you've nicely separated out into assess, improve, detect, and guide. Can you just walk us through some of the stages, some of the views, and then we can go from there?
Yeah, so we use this as a didactic help for people to remember it. So assess this would be, let's say, it's called the first step in assessing the rhythm, or helping to assess the rhythm when the ECG is not 100% clear. So you can be able to detect fine VF, maybe differentiate PEA, pseudo PEA, or even see good valve movement, where you might say on the echo, I think this patient has a ROSC. Let's be sure to check the pulses. And you can also see cardiac standstill in terms of termination of CPR, although this is not within the guidelines. I think we have to mention it, that ultrasound is not yet within the guidelines for termination of CPR.
Yep. The next step is improve. Talk through it. So you've made a diagnosis by the assessment bit, cardiac standstill, fine VF, as you said. What does improve cover?
So improve, and this is maybe the most important part, or one of the most important parts, is to improve chest compression quality. We all
explain.
Yeah, we all like to use, whether it's in hospital or pre-hospital, use a feedback device that's been given to us from the manufacturers of defibrillators. And this feedback device is then telling us you're pushing 5 centimeters at 110 beats per minute. You're doing a great job. And this is a good first step, but you don't know where you're pushing. Right?
Very true. Very, very true.
And so since we're all individuals, and a lot of radiology studies have shown this, when you perform a chest CT, the left ventricle is not always in the same place. Sometimes your proposed chest compression place is the the aortic root lies underneath it. Sometimes it's the right ventricle, and so on. So improve is really, what is your area of maximal compression? Is the left ventricle? Is it the aortic left ventricular outflow tract? Is your aortic root? Is it your right ventricle?
I think that's a very good point, and I'm sure Francesco would agree with me. Your outcomes, the best outcomes means excellent CPR, and as Stefan has pointed out, often with CPR chest compressions, where you put your hands, you don't actually know where you're compressing on. You might be causing more harm than good by obstructing the left ventricular outflow tract, so on and so forth. And that was one of the more convincing argument for me to say consider ultrasound, subcostal ultrasound, to make sure that chest compressions are optimal, and you can feed back in real time when it happens. Okay, then the next bit is D for detect.
Yeah, detect. So detect causes of cardiac arrest. They might be reversible or they might be irreversible. But with TE, we have the possibility to detect more causes, I think, than with TTE. And so we've listed in our publication pulmonary embolism, pericardial tamponade, and the aortic dissection. And especially the last bit is an important one, because the symptoms can mimic usual cardiac cause, like myocardial infarction before the arrest, but those people don't have a chance. And
I have to ask at this point. You started off this conversation by saying you were extending it from its use to help your cannulation in eCPR. So, in your setting now, Stefan, what percentage of out of hospital cardiac arrest patients will have a TEE probe put down? The rough numbers.
Yeah, I will try to give you a rough number. So it's maybe between 10 and 20%.
So the minority.
Yes.
Francesco, does it happen in your catchment area, out of hospital cardiac arrest, TEE happening?
No,
That was quick.
unfortunately no.
So again, in the UK, if you're lucky, you get a TE when they arrive in the cath lab and what have you. I know there are some of our colleagues, both Francesco and I know colleagues in America who have been advocating the use of transesophageal echocardiography in the context of cardiac arrest, in the context of shock perfusion management in the inpatient in hospital setting. I have to say, in the UK, probably it's the vast minority of centers that doing it. Francesco, is TE very much available in Pisa where you work, or not quite yet?
No, TE is available. We are not used to perform TE. Okay, and I think that is due to first, because since recently we consider the TE something advanced compared with the TTE. I think that we have to change our mind concerning this point, because in some setting, TEE should be considered the first approach, and sometimes the only one, like this kind of setting in out of hospital cardiac arrest. So I think that we have to recognize the existence and the necessity of a basic TEE approach by which we will be able to recognize very few points and another level of an advanced TEE. The same can also be true, for example, in the operating rooms for major surgery. I think thrombosis in the inferior vena cava during urologic surgery or so on, and also in ICU patients admitted to mechanical ventilation due to RDS or something like this. I think we have to change our mind and consider a basic approach also for the TEE.
I agree. We'll come to that later, but as a closing off discussion, just to finish up your stepwise focus approach, Stefan, the last thing after assessment, improvement, detect is to guide. Tell us a bit more about that one then.
Yes, and this is to guide the cannulator and giving him or her security if the guide wires are in the descending aorta, in the vena cava. So when you, of course, we do ultrasound puncture in the groin. Sometimes you can see it very good, sometimes you don't. Of course, you would know that. So we always confirm both guide wires in the right vessels, and only then we start to dilate the vessels and go with the cannulas. And then the venous cannula, we want to see it go through the right atrium into the vena cava superior. Of course, this has not. This can be at a later stage, so it would be possible if it's, I know, a bit difficult, so to leave it in the vena cava inferior and start the ECMO, and then when the ECMO is running and the patient is stabilizing, then to try and push it a bit further in, further up, and have it in the right place. As we use multi-stage cannulas, and this would be the best place for it. Of course, if you use other cannulas, then you might be able to leave it in the inferior vena cava.
I mean, I've read the manuscript obviously, but I've also looked at the supplementary videos you've included as part of the manuscript submission, and there's some really, really nice ones there. And I'll recommend our listeners, log in, have a read of the manuscript, but also look at the videos. There as a supplementary video 4 I can recommend as a very, very nice case showing. I'm not going to spoil it, but number 4 is my favorite one there. Just to round this off now. So you said that the 10-20% of your out of hospital cardiographs currently get a esophageal probe put down. What's the biggest limiting factor in someone like in your setting? Because you're clearly a believer. What's the limiting factor in all of this?
A limiting factor will be the team that is available. So we have the luxury of responding as a third tier.
Mm-hmm.
So to an ambulance, to an emergency physician,
Mm-hmm.
and then as a third tier with our ECPR team, we have 3 people, 3 physicians that are going out, and one is responsible for going through the checklist with the EMS team, performing the TE and placing the NIRS electrodes on the forehead.
Mm-hmm.
So
you got NIRS as well. Very well.
NIRS as well, yeah. So we have one person sitting at the head and doing the TE.
Okay.
While 2 are down doing the cannulation.
Fine. And I presume you're training more colleagues to try and get more proficiency to make it equitable, because it is a very, very, you think about it, you've said it yourself, you've got one person at the top end doing the TEE, you've got 2 people doing the cannulation. This is a very, very heavy workforce, high level workforce required for this. And I suppose that the next step is that what would you like to see next? What are you working on next in regard to this project, being it from a service delivery perspective or a training research perspective, Stefan? What are you working on next?
So we still have to see if changing the area of maximal compression can be beneficial in terms of outcomes.
Mm-hmm.
We know that in animal models it will somehow change hemodynamics.
Mm-hmm.
I think this is the next step, combining TE with an arterial line and observing how the arterial waveform or the arterial blood pressures are changing when we correct the area of maximal compressions. And if this can change outcomes, we will see. But I think doing this in hospital, so transporting the patients under continuous CPR in hospital and doing it then after 40, 50 minutes, this might be too late. And that's why we opted to go out and trying to change it after or control it after 20 to 30 minutes, something like this. Yeah. So having a look at the hemodynamic effects in out-of-hospital cardiac arrest in the pre-hospital setting and whether the patients can benefit from this.
So initially a physiological thing. I like the fact that you were looking at physiology there, definitely. Francesco, so what would you like to see from a scientist perspective as a researcher, but also as a clinician with regard to the topic of TEE in the pre-hospital setting?
Yes, I hope, and I guess that when these methods will hopefully spread enough, I would like someone to explain me what is pseudo PEA. Because I think it's a very, very important point. Because reading the manuscript it's very, very important to clearly understand that we can have PEA and pseudo PEA, but some manuscripts describe the pseudo PE like a movement of the ventricular walls with a reduction in size. Some others, a movement without a reduction in size. Some others, the only movement of the leaflets of the valve. So I think this issue would be very important because I think it is very relevant in order to know when to stop a resuscitation. Or even from the scientific point of view, how to change the management of these patients, because a PEA or a cardiac arrest with ventricular fibrillation needs to be managed differently. And furthermore, if you think that in a ROSC, a recognized ROSC, it's possible. You might perform compression producing a recurrent obstruction of the left ventricle outflow tract. You can, including harm. So one size don't fit all in advanced emergency systems. I think that this approach for sure could provide very important insights.
I agree. I really like the way you've structured it to assess, improve, detect, and guide. Clear-cut questions. As I said at the start, I'm not a TEE practitioner, but every now and then I meet friends and colleagues who said, "Adrian, come on, train up in this, do it focused," because as Francesco said, this is a focus assessment. This is not a comprehensive cardiology TEE or anything like that. And when I look at the way you've laid out the manuscript, you're going to diagnose, find VF, cardiac standstill, pseudo, those sort of things that will set you apart in terms of what your treatment strategies may be, and I think that's something that I will reflect upon and consider whether it's definitely a knowledge gap to invest in upskilling, because it will require upskilling for someone like me. Okay, any closing thoughts, Francesco?
Oh, a lot, but I don't want to be so boring. I suggest to our readers to read the manuscript, because it's a short manuscript, but with a lot of links to physiology and pathophysiology. And you can clearly understand that it's written by people that usually do this and perform this in their real life. And this is a manuscript on TE, on out-of-hospital cardiac arrest, one of the many but it's completely different from the most. And as an editor-in-chief, I have a huge responsibility, because when you can say whatever you want, and you can go to Congress and have an abstract and whatever you want, but when you get published, it is supposed that what you are reading is okay, and eventually you can improve and change your clinical practice. And in this manuscript, during cardiac arrest, not during cardiac arrest, this is the first that I wrote that a dilated and enlarged right ventricle is always present. So when I read that if you found small ventricles, okay, no bleeding for sure. Hey guys, what are you saying? Editor-in-chief, reviewers. I guess I'm not a specialist, but I want to ask to Stefan, facing with a cardiac arrest. So what's first? Compression, I think, not TE. Okay.
Yeah.
Okay. So you perform maybe TE, but for sure after 3 minutes. So the right ventricle will be enlarged. So please remember pathophysiology. And please, for the readers, read the manuscript. Are not all the manuscript equals, but please read this manuscript, because if you find something different from other manuscripts on the same topic, one of the both is wrong.
Okay, so but genuinely, as I said, when I read the manuscript, it promoted a bit of self-reflection in terms of whether this is something I need to upskill about. And the other thing I like about the manuscript as a closing thought is that there's something for everyone. So what I really like about it is that it touches a bit about the training side of things. It touches a bit about the logistics side of things. It talks a bit about the risk side of things and the structure. So we're all slightly different. There are some things that are more important. Some of us are definitely scanners, and equally, some of us have provisions and responsibility to look at it from an implementation perspective. So this, I think, will stimulate interest, discussion amongst colleagues in the field, which will hopefully mean that more people start talking about it and discussing it. So as a closing thought, thank you very much, Stefan, for your hard work in putting together the manuscript. We are very, very grateful for you submitting it to the Ultrasound Journal, and for you being here, taking the time to come and talk to us a bit about this paper. Thank you very much, and congratulations once again.
Thank you for the invitation and the possibility to talk about this exciting topic.
Thank you very much. I'm sure people will get in touch if they've got any questions, and we look forward to the conversations that follow on. So thank you, everyone, and have a good day. Bye.
Thank you. Good day.